right, thank you so much. All right, so I recognize that I stand between all of us and lunch. So, but I think this is still very important, and I think is one of the, all of it. It's just been it's just so exciting, and I'm so grateful to, for all of you guys who are joining online, for all of you guys who are here in person, to be able to kind of talk about and show the progress that we've made with A-Link over time. And so I'm going to be talking specifically about the prospective arm, but I also wanted to just kind of take a pause because we've heard about kind of model care guideline development and the retrospective database. And we've kind of alluded to how everything kind of fits together as part of these larger puzzle pieces. But I just kind of wanted to kind of go a little bit back into the roots of, why this is important and why this prospective study I think is needed. And so as we talked about, there are the optimal strategies for disease remission in pediatric AILD. They're incompletely defined. These are rare diseases. We've talked about the variations in care practices. There has not been traditionally a mechanism to implement research discovery into clinical practice and be able to see directly in kind of a real-time way how this is actually affecting outcomes in patients. There's a limited focus, as we were just talking about, on mental health, quality of life, and patient-reported outcomes. And there was an absence of kind of a community. We wanted to create a community for everyone to be able to talk about these important things. And so we've always felt that multi-centered collaboration is important. And so we have implemented a learning health network framework. Really, at its heart, to deliver the best care to kids with autoimmune hepatitis and PSC, to expand knowledge beyond single center and retrospective studies. That's where kind of this part comes in, and to develop solutions to be able to improve outcomes. And again, highlight that we want to really also not only focus on the numbers as our patients have told us, but to also say, how are they doing, to do patient-reported outcomes and quality of life. And I think that this has been a really great feature of having kind of collaboration amongst kind of all of the patients and the providers and the advocates and the families. It's just been, I think it's changed the perspective of how we're able to approach research, and I think that it's going to fill a need in not only the literature but also in the clinical management of patients. So these are our A-Link sites. We have providers joining us online. You've heard from some of them today. And we also have providers who joined us in person. And we have patient representatives and parent representatives from many of these centers. And from some who are not part of, who are at centers who are not enrolled, but we're working on it, right? So this is just kind of an interlude to talk through kind of the overview of A-Link. You've heard multiple pieces. And I think that the hallmarks is that it's multi-center patient caregiver engagement. We're partnered with the Improved Care Now network, which is a very large established IBD, inflammatory bowel disease network. And we have many interrelated efforts, quality improvement, research, advocacy, and this kind of highlights these. And you're going to be hearing kind of a lot about these different aspects today. So next you'll hear about from A-Link Connections. We've talked a little bit about the work that's been done in the working groups. We are doing interventions and looking at outcomes at our sites. We engage regularly with the ICN leadership team, with quality improvement specialists, project management analysts. And you've heard about the multi-center retrospective from Dr. Sakil Kulkarni. And today I'm going to be talking about this arm of it. So this is the multi-center prospective registry. Overall, though, our goal is to improve outcomes. And I think that's the common thread for all of these different efforts, is to make meaningful improvements in outcomes across a variety of different things. So because we're talking about quality improvement research, it wouldn't be complete without the key driver diagram. And this is really kind of what anchors a lot of the focuses and how we've been able to make sure that the different aspects of what we're doing within A-Link are all kind of moving towards the same direction and are complementing one another. And so nothing is kind of done in isolation. This perspective is very much anchored in the works that we're doing for improvement efforts, anchored in the work that we're learning to identify baseline outcomes at our centers and across the network. And then also in the individual care that we're able to provide patients at a center level, at a provider level, and ensuring consistency. I'd like to speak a little bit about the partnership with ICN. We've talked about the overlapping patient populations, that 70%, 75% of children with PSC also have inflammatory bowel disease. There's common threads in how we treat diseases such as immunosuppression and goals of remission and autoimmune hepatitis. Also, we have patients who have both, that we need to have a collaborative way of managing the diseases and ensuring that we are on the same page. Again, overlapping clinical practice and providers. And what it's been really neat about this is instead of having to start up all of these arms, we've been able to kind of tag along. They've shared freely with us, the aspects of it. And it's enabled, I think, more rapid growth and development of the efforts of A-Link, including this prospective. So this is our overall, this was not quite a position statement, but though I think what drives a lot of this is that children, teenagers, and young adults with autoimmune liver disease will have better outcomes by utilizing a learning health network model to optimize treatment, limit medication side effects, reduce hepatobiliary clinical complications, and improve quality of life. And I think it's worth emphasizing that aspect. So we'll talk about the multi-center registry. So the research aims, so they're numerous. And I think what's unique about this prospective registry is that it includes patients with autoimmune hepatitis, PSC, and autoimmune sclerosing cholangitis. And that was intentional because there's a spectrum of disease. As we talked about yesterday and today, there's sometimes some, re-looking at kind of disease and phenotype, and we really thought that we needed to look at it all together. And so these are some of the individual kind of research aims. So to determine biochemical remission rates, factors influencing quality of life, the impact of GGT normalization, hepatobiliary outcomes in PSC. This is predominantly been done in a retrospective fashion. And then also to look at outcomes with implementation of QI-based strategies. We've talked about pre-visit planning, which is where we meet beforehand in a thoughtful way with a structure to prepare for patient visits to make it hopefully seamless, comprehensive, and really patient-focused. And also you heard about the model care guideline development, which kind of goes in with that hand in hand to be able that we have all of this information. Now, what do we do with it? So how we can provide the best care. And then I would say more to come. So the heart of this is documenting patient experiences. So we have a REDCap database that has been built and trialed and is now actually we're entering patient information from patients who've been enrolled. And so this is a study where patients and families undergo informed consent. This is opportunity to learn more and ask questions about the study. The data, it's really right now, it's just data collection. There's no biospecimens, there's no extra asks, there's no, but it's the ability for us to collect targeted clinical data associated with the time of a clinic visit, either via telehealth or in person, to be able to kind of track over time how patients are doing. And this is very much aligned with the ICN model for how they've tracked outcomes in pediatric inflammatory bowel disease. So some of the data that goes into this is results of lab tests, reports from imaging studies, medications, complications, growth, nutrition, and bone health is built in. And I think a really important one, and one that our patients have really had a big part of, is symptoms and quality of life. And so we are assessing at every visit symptoms. And I think the benefit, even beyond a research standpoint, is it's starting to change how we talk about what we need to, from a clinical management standpoint, for patients. And so this is something that's directly impacting patient care, to be able to make sure that all of our providers are asking about this, are focusing on these things. The health-related quality of life is actually a survey that's sent out. It's targeted for, it's based on age of the patient, and then it's a parent or caregiver. and a patient response. And that's actually sent out automatically through the REDCap database. And so we're hoping that we'll be able to really look a little bit at, because we're collecting medication data, how are patients feeling? We do know that there is some literature that supports that steroid dose is related to quality of life assessments in patients, and we'd really like to be able to characterize that further. So it's a fabulous question from the last session, and something that we're hoping, it's a little bit harder to look at that retrospectively, and I think that's one of the benefits of having a prospective database that's meant to look for that aspect too.
Amy, we were just talking about sleep as a domain of quality of life and mental health, which we actually did not mention as a symptom yesterday in our discussion. Related quality of life, are there any questions on sleep?
I believe so. So, and fatigue is one of the key symptomatology we're capturing as part of the database going forward as well. So research progress. So I actually was looking back at old slides and gave this talk last year, and we made a lot of progress since then. And it's exciting to kind of show where we've been, but where we are now. So you can see kind of on the right, we have 33% of sites that are active. This is out of 11 centers. 22% are initiated, but we're still working on getting enrollment. 17% are actually screening and enrolling, and we're still awaiting some degree of approval process for the other 28%. The key learnings have been, this is taken approval from institutional review boards, contracts and agreements. Like I said, the registry database has been built and tested. I think a key thing is patient involvement and enrollment. And so we're really grateful for the patients and their parents who have partnered with us to be able to create this registry. And I think that's the most important part is that engagement. We've had some data collection, some review and analysis, and then of course sharing of findings with the community. So you're going to get a sneak peek at the first part of the data. So this is results. I did not break down the patient characteristics. I think it's too few patients, and I think I wanted to just for patient anonymity. I think we can do that when we have more patients. Currently the data is from Cincinnati Children's, and these are kind of this is how we've been working with one of the analysts to kind of outline, and this is how we're going to be tracking outcomes. So the first one is the percentage of autoimmune hepatitis patients and autoimmune sclerosing patients in biochemical remission. This is at any time point. So this is if they were diagnosed a month ago, this is if they were diagnosed 3 years ago, just kind of a snapshot in time of the patients that we saw during this period of time, how many were in remission. So there's 9 patients with autoimmune hepatitis and sclerosing cholangitis. The overall remission rate is 80%. And then the caveat, it's not based on disease duration. What this is important for is as kind of a snapshot in time, that as we start to do improvement efforts, we can kind of see, hey, are we having any type of signal that maybe we're having not so great outcomes, or hey, are we having a signal that we're having better outcomes? So in terms of the percentage of patients with PSC and autoimmune sclerosing cholangitis with normalization of GGT, we have currently 3 patients enrolled in this. Enrollment began in March 2022. The normalization rate is in about a third. And again, this doesn't differentiate based on disease duration. We are working on the parameters. The next parameter that we're going to trial kind of display is the steroid-free biochemical remission rate. We have talked about whether we do that all comers or if we look at 6 months and 12 months. And I think realistically, the guidelines say, and our recommendations are, we're going to consider kind of steroid-free remission after 6 to 12 months. And so we'll have that reflected in our outcomes. And we're working on kind of getting that modeled within the data. So next steps. So we talked about the steroid-free biochemical remission, health-related quality of life assessment. We're going to be building out outcomes measures that we can report out for individual sites and for centers. And again, I think, currently this is single center data. I know WashU has started, has been initiated, kind of our early initiators, and they're going to start adding adding patients and enrolling patients. And so it'll be important for us to be able to kind of see kind of across the network. Need to onboard a few more sites. And then in talking with our statisticians, the goal, we need to establish baselines across the network. So what can we expect across not just one site, but other sites that kind of use our baseline values for us to be able to do improvement efforts with. And so it sounds like it'll be about 30 patients per month for 12 months to establish that baseline. But I think we're off to a really great start. It's been a lot of progress. So thank you to all of our sites. Thank you to all the patients, parents, and then also to all of the A-Link team who have really spoken into how we've designed this and how we've rolled it out.
We have 24 viewers online. Jen, do you have any questions in the chat?
I have 2 questions for Dr. Kulkarni's visit.
Well, let's have Sakil and Amy go up there, and Jen is hopefully still. Let's have 10 more minutes for these questions, and in particular those who virtually, which we really appreciate, and it's so important for the future of A-Link to have everyone being able to be online.
Question, Dr. Kulkarni. It will be important to eventually think about how lab values correlate with histology. Are there parallels to our surveillance biopsies in our liver transplant patients where normal labs don't always correlate with histologic control?
So yes, is this, I'm guessing the question is related to withdrawal of immunosuppression where we have normal labs and does that correlate to histological remission always in liver biopsy? And I think, again, I can't quote studies to that, but in our experience, we do, after a couple of years of withdrawal of steroids, we do have this discussion with our parents and do a liver biopsy. And in our experience, normal labs have not always correlated with histological remission as defined by the International Autoimmune Hepatitis Group, and we have not. I mean, the withdrawal of therapy completely based on normal labs is rare. I would say that.
But maybe, sorry if I can also respond to that, highlighting the retrospective A-Link, because you capture how many patients, which patients gets a repeat biopsy. So while we cannot answer these questions now, but if those questions are felt to be relevant, future ancillary studies would be easy to be executed, because we can look for each site which patient had a liver biopsy with normal LFTs, and we could have a relatively easy to perform answer, because I completely agree, super important question, and A-Link can answer it.
We're also collecting kind of not only did they have a liver biopsy, but what did it show in a very systematic process. And so we should be able to identify our certain features more characteristic in that setting too.
Same person had a little bit of a follow-up question, and it was more about Alex's comments about the ALT, AST levels being in the 20s versus the 40s. They said they wanted to know if slightly higher AST, ALT don't correlate with long-term fibrosis, maybe we can tolerate that a bit. So they're looking for the follow-up on the discussion that you had as well, Alex, on that. Another question was, Dr. Kulkarni, is there data on remission on only Imuran with no steroids?
Oh, in autoimmune hepatitis, again, I'm not aware of literature where just Imuran has been used for induction of remission and maintenance of remission per se. I think most studies and most patients have used either budesonide or steroids, even in the adult world, for induction of remission, and then there's data on azathioprine for maintenance.
Shaw published a case data of Imuran only with induction.
Oh.
And they say they have good, but I think it was 5 or 6 patients. Imuran only.
Do you know how old that study
Yeah,
is?
it was maybe 3 years old, 3 or 4 years old.
I would just note that that's also tricky too, because I think that if you have patients who have a cholestatic phenotype associated with their autoimmune hepatitis onset, that we typically can't use Imuran, or we typically try not to use Imuran unless the bilirubin levels are nearly normal, because of the concern for potential additional hepatotoxicity as you're initiating it. So just kind of cholestasis at time of diagnosis is sometimes when we'll hold off on using Imuran for a little bit until using steroids as kind of a bridge to get some of the cholestatic phenotype improved.
Yeah, ditto at our center. We wait for the acute severe presentation.
But I think that, I think corticosteroids again are one of our number one priority, because I think we all see the side effects, and if they're, variability. I think the IBD world has made a lot of progress in limiting the use of steroids. And I think it's something that we're hoping to learn from. Sure.
Is it okay if I go on with more information from the chat? Great. A couple comments that to Dr. Taylor's presentation. They were very excited to see the progress in A-Link, and follow-up question. Thank you to Dr. Kulkarni. Thank you, my daughter, with only Imuran, and she would love to know the name of the study, but I think we can maybe work with Dr. Squires on getting more information on that study. Get that out. There was a question that was answered in our Q&A section. The question was, in Dr. Squires' presentation, wondering how you chose the ursodiol dose for the recommendations. And the answer to that was based on AASLD guidelines and for PSC management. And that's all I have here in the chat.